Good afternoon, everyone, and welcome to this webinar on the management of tricuspid regurgitation and heart failure. This is the first webinar of a series of webinars organized by the PCR Tricuspid Focus Group, coordinated by Francesco Maisano and Fabian Prats, in collaboration with other societies. This webinar today is in collaboration with the Heart Failure Association. Let me present the team of today. My name is Marianna Damo. I am interventional cardiologist and heart failure specialist from Italy, and it's a pleasure to co-chair this webinar with Marco Metra, president-elect of HFA. Then we have online Giuseppe Rosano, president of HFA, and Andrew Coates, past president of HFA. So we have the complete president's trio today. And then it's a pleasure to have online also Ovidio Chionsella, member of the HFA board and expert in acute heart failure and right heart failure, Philip Lurz, interventional cardiologist and expert in the transcatheter treatment of tricuspid regurgitation. And finally, it's a pleasure to have here at the studio Julia Grapsa, expert in imaging of the tricuspid valve.
So let me introduce and focus the problem of tricuspid regurgitation in the patients with heart failure. We know that approximately 20% of the patients, of our patients with chronic heart failure, have moderate to severe tricuspid regurgitation. Moderate and severe tricuspid regurgitation is associated with more than a twofold increase of persistent congestion after an hospitalization for heart failure, and it is an independent predictor of increased mortality in heart failure patients, regardless of concomitant diseases and comorbidities. So nowadays we will focus on possible causes of secondary tricuspid regurgitation, its early identification, what medical treatment can do, what hemodynamic assessment must do, and the possible treatments of tricuspid regurgitation in our patients. So it's now my pleasure to leave the podium, in the virtual podium, to Philip Lurz, who will present the first clinical case. It will be followed by Julia Grapsa with the second one. So, Philip.
Thank you very much, Marco. So I'd like to present and discuss with you a patient we've seen very recently at our center. This is a 73-year-old male patient with progressive dyspnea, peripheral edema, and incipient ascites, and he was an MYHA class 3. He was known to have a persistent AFib for a very long time, chronic kidney disease, and also diabetes. Here you can see his baseline medication, which includes a full dose of beta blocker, a cumulative dosage of torsemide of 50 milligrams per day, and also candesartan at full dosage. On physical examination, his blood pressure was found to be rather low, and there was suspicion of elevated jugular venous pressures, also illustrated by this quite marked jugular venous pulse, as illustrated here. For further assessment, the patient underwent echocardiography, transesophageal echocardiography. This is demonstrated here, and these images demonstrate and very nicely depict a significant tricuspid regurgitation, which was graded as torrential TR, so grade 5 TR. We also performed right heart catheterization, which demonstrated the ventricularization of the right atrial pressure curve, which is very typical for significant TR. And we could also see very high PA pressures, systolic PA pressures of 80 millimeters of mercury, and mean PA pressures of 40 millimeters of mercury, so pulmonary hypertension. If we then focus on the left heart, you can see on that transthoracic echo that left ventricular function was preserved, and there was a suspicion of relevant diastolic dysfunction with increased E to E prime. In addition, again, on invasive assessment, wedge pressures were increased, mean 27 millimeters of mercury. So in conclusion, that patient fulfills the criteria for HFpEF with combined pre- and post-capillary pulmonary hypertension. We also performed a magnetic resonance scan in this patient. What you can see here on the left-hand side is a short axis view through the left and the right heart chamber. The right heart chamber is the larger chamber. It occupies the larger part of the pericardial sac, and due to both pressure and volume overload of the RV, the septum bows towards the left ventricle. And this adds to the very specific pathophysiology of the combination of HFpEF and TR. And this very specific pathophysiology is summarized here. So as we know, in HFpEF, we have increased left ventricular and left atrial stiffness. This causes post-capillary pulmonary hypertension, causes RV pressure overload, RV failure, tricuspid annular dilatation, TR, and as a consequence, because we have right ventricular volume and pressure overload, the unfavorable RV to LV interaction with the septum bowing to the left, particularly at early diastole, we have the problem of HFpEF, with diastolic dysfunction, and on top of that, a septum which further restricts LV filling. And these are the final images with a special focus on the right on transgastric view, which might be relevant if we would like to answer the question whether that tricuspid valve could be approached by transcatheter means. Thank you very much.
Thank you, Philip, for this excellent case. And now Julia will present the second case.
Thank you so much, Mariana and Marco. So we are presenting our patient, and who is actually 61 years old, a male patient, clinically coming in New York Heart Association class 3 with shortness of breath at 300 meters. He doesn't have any complaints of chest pain or palpitations, and he doesn't describe any orthopnea or paroxysmal nocturnal dyspnea. From his medical background, he has a known dilated cardiomyopathy with severe LV impairment, as it was calculated 15% on the cardiac MRI, and he had normal coronary angiogram. I will discuss the right heart catheterization a little bit later. So he had also previous flutter and now permanent AF, and he has also hypertension, gout, and diabetes with 15 years in history on insulin. And he had the primary prevention ICD upgraded to CRTD in 2021. As you can see from his right heart catheterization, his mean right atrial pressure is 20 millimeters per mercury, RV end diastolic pressure of 22 millimeters per mercury, and mean pulmonary pressure of 33 millimeters per mercury. End diastolic pressure of the left ventricle was 18 millimeters per mercury, and also his mixed venous saturation was 52.2% and pulmonary artery saturation of 55.2%, and cardiac output from the FIC calculation was 4.3 liters per minute and PVR, pulmonary vascular resistance, of 3.4 Wood units. He was also on optimal medical management with sacubitril valsartan twice daily, carvedilol 50 milligrams twice daily, eplerenone 25 milligrams every morning. Bumetanide was increased to 3 milligrams from 2 milligrams every morning, digoxin, amiodarone, insulin, metformin, dapagliflozin, and warfarin. As you can see, his BMI was 27.4, he was normotensive, and physical examination demonstrated holosystolic murmur or cardiac auscultation. And from his blood, the pro-BNP was 3,355. As you can see, he has iron deficiency anemia with low iron levels and HB of 112. And he also has renal impairment with eGFR of 38 and creatinine of 161. From his echo, we can see that his LV is severely impaired, and also with a thorough examination of the RV from multi-parametric approach, we can see that the right heart is dilated, the right atrium is severely dilated, and there is also a coaptation gap between the tricuspid leaflets that ends to severe tricuspid regurgitation, and an estimate the peak gradient is 33 millimeters per mercury, and the right ventricular systolic pressure is from 43 up to 47 millimeters per mercury because the inferior vena cava was dilated with reduced respiratory collapse. Also here, as you can see, the LV is severely impaired. And we had some images from a TOE that was performed during his EP procedures that verifies the severe tricuspid regurgitation and the dilate tricuspid annulus because of the dilated right atrium. As a summary of the echo, the patient has moderate severe RV systolic impairment, severely dilated right atrium, slightly increased pulmonary pressures. The TAPSE was 12 millimeters in the context of severe tricuspid regurgitation. The RV free wall S prime wave was 11 meters per second, and also the acceleration time from the RV outflow tract was 70 milliseconds. We also calculate the tri-score, which was 5 out of 12, primarily from the LV and RV dysfunction, and the predicted in-hospital mortality for isolated valve surgery was 14%. And as a summary of the patient, we have a 61-year-old male patient with severe TR, severe LV impairment with a background of dilated cardiomyopathy, and also optimal medical management and CRTD, and we are discussing about whether he is suitable for structural intervention.
Thank you, Julia. So we'll see the resolution of these two cases and the treatment of these two patients later. Now the discussion is open, and I would invite the online participants to make comments and questions using the chat. In the meantime, I have a question regarding the cases to Julia and Philip. So we have seen that both FPEF and FREF can cause tricuspid regurgitation. And the main mechanism probably was the pulmonary hypertension causing right ventricular dysfunction. But both patients also had atrial fibrillation. Do you think that atrial disease could have played a role in the pathophysiology of tricuspid regurgitation? And what about the pacemaker lead in the second case, Julia?
That's a great question, Mariana. And I will start actually with pacemaker, the lead-induced tricuspid regurgitation. My patient, we can say that he had 3 different etiologies. So he had initially an ICD lead, which certainly contributed to tricuspid regurgitation. Then he had atrial fibrillation. He has atrial fibrillation, which contributes to the dilatation of the right atrium and, deterioration of tricuspid regurgitation. And also, there is a possible septal impingement due to the lead. So I will actually discuss a little bit with leads, which is a very interesting topic because a lot of patients present with tricuspid regurgitation because of device-related, tricuspid regurgitation. And it's more than we actually thought before. There are many studies that they show that ICD leads have a higher propensity of tricuspid regurgitation. There is a huge spectrum of the etiology. For example, it can be simple impingement on the leaflet, or it can be even avulsion of the leaflet. So this could be identified with a thorough examination on the echo, and many documents have suggested actually multi-parametric approach with multiple views from a transthoracic and transesophageal echo, and that helps us not only identify the cause, but also, most importantly, identify where is the problem, for example, either at the commissures or more central, or even if it's affecting, let's say, the septal leaflet, that will affect the management. Whether we will need to do lead extraction, whether it's important for tricuspid surgery, or whether for you as interventionalists, whether you are able to perform TriClip or another, intervention with the pacemaker lead in situ.
Exactly. Philip, what about your patient?
Yeah, you asked the question about the coexistence of AFib and TR, and obviously this is a scenario which is extremely common. Almost all patients with a significant TR also have AFib, and obviously TR can worsen AFib and can lead to AFib because it leads to right atrial remodeling. But then at the same time, again, AFib can also cause TR because AFib will increase right atrial volume. It can cause the tricuspid annulus to dilate. And this leads to a very specific kind of functional TR, which is atrial functional TR, which is normally the early stage. And I would assume that our patient has started off with such a condition with functional atrial TR, which means that obviously, as always in functional AV regurg, there is dilatation of the annulus causing a certain coaptation defect of the tricuspid valve with pretty much normal leaflets. But at least at an early stage, we see quite often normal RV volumes, normal RV function, and the main cause of tricuspid annular dilatation is really merely due to atrial dilatation rather than ventricular dilatation. But then obviously at a later stage, because TR causes RV volume overload, the RV will remodel, and then we will have the ventricular functional component on top of the initial atrial functional component. Either way, although a bit complex, I think it's important to think about functional TR with two different phenotypes, ventricular and atrial, whereas atrial normally is the sort of the beginning of the disease, and then ventricular the later stage.
Exactly, very clear, Philip. Thank you. So before looking at the chat, I have a question for our heart failure specialist. So we have seen from our two cases that in both patients, the stage of disease was quite advanced. And this is quite common because often patients with secondary tricuspid regurgitation come too late to our attention for specific treatments. So my question is, how can we identify earlier tricuspid regurgitation in patients with heart failure? And on the other hand, in a patient with clear signs and symptoms of right heart failure, how can we assess the organ damage and its reversibility? Giuseppe, do you want to start?
Yes, thank you, Mariana. I think there are a couple of issues. The first one is we have a pure tricuspid regurgitation that is isolated. Patients won't get any symptoms until it's too late. And sometimes we may pick up the disease just because of some hepatomegalia or because of abnormal liver enzymes. But as you said, these patients tend to come very late. On the other end, we can. There's also a link with what has been discussed earlier with atrial fibrillation, because some patients may, because of the stretching of the atria, develop atrial fibrillation as a first symptom. But in patients with heart failure, I think that is mostly our failure to identify them, because it's sometimes we tend to overlook the tricuspid regurgitation. And in patients with heart failure, that assessment should be part of our diagnostic pathway. And therefore, picking up a tricuspid regurgitation when it's late is more our fault rather than anything else in patients with heart failure. Regarding the reversibility of the target organ damage, I mean, we have a lot of different tests for the liver, and today they are mostly predictive of future deterioration rather than predictive of recovery. For example, the elastography of the liver has a role in diagnosing liver disease, but where they can predict the reversibility, that is still a matter of speculation.
Thank you. Andrew?
Yeah, I'd follow up and very much support everything Giuseppe said. I think the most important thing is a high index of suspicion. I think that often clinical evaluation doesn't really concentrate on the tricuspid valve or even the right side of the heart, that we might pick up the signs but not consider them important enough. And as Giuseppe said, symptoms come quite late, and therefore symptomatic complaints not the most important thing. So we've got to go back to basics and have good clinical evaluation, good auscultation, observation of jugular venous pressure, measurement of hepatojugular reflex, examination of the liver. And tricuspid regurgitation can be picked up clinically quite well. It's just it has to be noted and it has to be followed up. Then the important thing is, do we look for organ damage? Now, we often assess renal function, but I guess most people aren't thinking of tricuspid regurgitation being a mechanism of deterioration. We more think of the perfusion, the left side of the circulation. We don't regularly look at liver function tests and consider that tricuspid regurgitation could be common in that. And we don't look at malabsorption, even though we know that malabsorption and consequent calorie problems and cachexia are quite common. Therefore, we just don't think about the right side enough, the tricuspid valve. Index of suspicion, and I think we'll do far better.
Thank you. Ovidio?
So I'm just echo what Andrew and Giuseppe said. Clinical examination is really, really very important, but it's not always very easy because severe tricuspid regurgitation can mimic any systemic disease, and specificity of heart failure signs and symptoms for tricuspid regurgitation is rather modest. However, a constellation of clinical signs such as jugular pulsability, as you said in previous presentation, liver pulsability, and hepatojugular reflux may determine to search for a tricuspid regurgitation from echo perspective. Any left side pathology may produce tricuspid regurgitation, and the echo exam should be comprehensive, including assessment of right ventricular size and function, pulmonary hypertension, and severity and mechanism of tricuspid regurgitation. To distinguish in terms of reversible versus irreversible organ injury, it's also not so easy. We need dynamic assessment of organ function markers. As Giuseppe said, we need liver elastography, and probably we should follow more closely hepatic synthesis function markers such as cholesterol and triglyceride. And I should remember at the end of all clinical relevant scores for tricuspid valve surgery and also for interventions are including organ function markers.
Exactly. And this is because probably it's too complex to make all together. Anyway, Marco, do you want to add something?
Yes, I still have time.
Yeah.
I think we are depicting two main scenarios. One is the so-called atrial tricuspid regurgitation. These patients have may have a normal left ventricular systolic function. They have atrial fibrillation. They have a systolic murmur, which is another important clinical sign of tricuspid regurgitation. And as we will see, probably in this stage, also any percutaneous intervention is more likely to change the clinical course of the disease. On the other side of the spectrum, we see patients with reduced ejection fraction, systolic dysfunction, and in these cases, tricuspid regurgitation and right ventricular dysfunction. There is also a question regarding right ventricular dysfunction. We will deal with this. In this case, we have the systemic consequences of tricuspid regurgitation, kidney dysfunction, diuretic resistance, which is an hallmark of severe kidney dysfunction and tricuspid regurgitation. And we may have also liver dysfunction and malabsorption with cachexia, as Andrew Coates nicely pointed out. So we have these two extreme, and the earlier we detect tricuspid regurgitation and treat it, the better it is for the patient. And thinking about the patients with preserved ejection fraction, we must remember that many of these patients are seen by primary care physicians and first-level heart failure specialists. So, I mean, it's really time that we move to a more widespread awareness regarding tricuspid regurgitation and heart failure treatment. So,
Perfect. Julia, do you want to add some words regarding the right ventricular assessment by imaging? I don't know, pointing out, for example, the difference between echocardiography and cardiac magnetic resonance.
Sure. So Ovidio actually already mentioned the comprehensive echo exam is a key on how we are guiding the management on these patients. I will add actually that it's a multi-parametric approach. I think we need to say this again and again. We have several parameters to assess the right ventricle, the right atrium, and also a proper tricuspid regurgitation assessment. Starting from the tricuspid regurgitation, we shouldn't forget technical parameters such as the alignment of the continuous wave Doppler. For example, the appropriate calculation of the effective orifice area or vena contracta. And for example, for the right heart, markers that they are volume dependent, such as TAPSE. We have seen TAPSE being used even in clinical trials. However, we shouldn't forget its limitations, that it's volume dependent and also it only reflects longitudinal function. We have other parameters such as the volumes, the ejection fraction, the strain of the right ventricle. And I would say that even, for example, now we have the right atrial volume, other like direct and indirect measures such as the acceleration time from the right ventricular outflow tract, the S prime wave that is reduced. So we need to keep in mind which indices are volume dependent, the limitations and technical parameters in order to make sure that we have an accurate assessment of right heart and also the tricuspid regurgitation. Now, cardiac MRI is an amazing tool that comes as supplementary, and I hope the CMR specialists will excuse my words, but I think the echo is of course first line modality because it's also used as bedside and it's easier to follow up the patients. Cardiac MRI is an amazing tool for calculation of volumes, the gold standard for the ejection fraction for the right heart. If we want to use gadolinium enhancement, to exclude the cardiomyopathy, also to identify the right ventricular outflow tract in congenital patients. So it has exceptional advantages that we should never forget.
Thank you.
And Julia, we also have a question two questions from the chat. One is the role of right ventricular function, and you answered. The other one maybe can be replied later, is how the lead, right ventricular lead, may influence the device selection for transcatheter treatment.
That's very interesting.
Yeah.
Mm-hmm. We have time to reply.
Yeah.
Please, Julia.
So,
if you want to start.
As the first question, actually, when we should always, as imagers, give the answer to our colleagues, heart failure physicians, interventional surgeons, about not only the tricuspid regurgitation, but also the right ventricle. The status of the right ventricle influences the decision, and we have seen, for example, that percutaneous interventions when the patient has an ejection fraction less than 45% maybe have different outcomes when compared to a healthy, good right ventricle. Also, I forgot to say, think about other measures. Sometimes now we have the emerging use of stress echo in order to assess the right ventricular contractile reserve. If we are unsure about the contractility of the right heart, it has been used actually with limited use of, but I think it may have indication in the future. Now for the next question, we saw from transthoracic images and few TOE images that there was a possible impingement of the septal leaflet. Now, I was discussing earlier with Mariana that when it is the septal leaflet, as an interventionalist, it's very difficult to implant the triclip, while actually when it's close to the commissures or if it's more central, it's easier. And sometimes even when we employ tricuspid valve replacement percutaneously, then this will actually leave the lead outside of the valve. So depending on the anatomy of the tricuspid valve and where exactly is the issue with the device, then we will give the images to our colleagues and they will decide which device is the best for the patient, depending also on the clinical picture, whether they are eligible for a triclip or they need tricuspid valve replacement.
Perfect.
Exactly. You have another question from the
No.
chat? No? Philip, do you want to add something about the anatomical characteristics of patients suitable for transcatheter interventions?
Maybe one comment about the lead. Yes, it makes the procedure maybe a little bit more complex, but the most difficult part, and Julia said that, is determination of whether the lead is the main cause for TR, or whether it's just an innocent bystander, or whether it contributes only partially. Because obviously when it's the main reason for TR, when the lead is the main reason for TR, then repair will be difficult, but replacement might be an option. And then in general, I mean, we mainly perform repair at this point in time with two devices. I'm having CE marked for edge-to-edge repair, the TriClip and the Pascal device. And there, the main criterion is the gap. The gap is the main criterion, and the magic number is about 10 millimeters. And anything beyond that makes it really difficult to bridge the gap, and that's exactly what we have to do during an intervention, bridging the coaptation defect, and it's difficult to bridge more than 10 millimeters.
Perfect. So we have to look at the clinical characteristics of the patients at the stage of disease, but also at the anatomy of the tricuspid valve. So I have another question for our heart failure specialists. While for the functional mitral regurgitation, we have a clear algorithm in our guidelines regarding how to treat these patients, how to optimize medical therapies before possible intervention on the mitral valve. We don't have specific indication for tricuspid regurgitation. So my question is, do we have to optimize medical therapies in these patients, and how can we do this? Andrew, do you want to start?
Okay, I'll start off. Well, of course, we've seen that functional tricuspid regurgitation occurs in a number of different settings, and all of them will indicate different guideline-directed medical therapy. We have atrial fibrillation, we have secondary to left heart disease, and we have secondary to pulmonary hypertension, and they all have different recommended background therapies. I think even though we don't have specific large trials that have looked at the evaluation of interventions and their effect on patients with functional TR, I think absolutely we need to optimize the medical therapy for any condition the patients have before we then evaluate the severity and the impact of the TR. Particularly in the patients with HFrEF, then there are many treatments that are poorly implemented in routine clinical practice, and we need to optimize those. And there have been one or two registries that have shown that in patients who do have up-titration of HFrEF therapy, the TR can actually improve, or the proportion of patients with moderate severe TR can go down. Similarly, a secondary analysis of the COAP trial has showed that those patients, in all patients, moderate to severe TR was a marker of worse outcome, but those patients who were randomized to the MitraClip actually had a better impact with moderate and severe TR. So therefore, at least for HFrEF, we really need to optimize all therapy. In terms of functional TR without HFrEF, then optimization of diuretic therapy is key to make sure that the fluid and volume status is optimized before we assess the overall severity of TR.
Thank you, Giuseppe.
No, I agree entirely with what Andrew said. The issue is when we identify and in which patient we identify the TR. Because if, as Andrew said, we have patients with HFrEF, then we have space for implementation of therapy, and that may improve the TR and therefore maybe reduce the amount of TR. Different stories when we face a patient that is either fully optimized on HFrEF therapy or as a severe TR, and that becomes symptomatic. In that case, we only have diuretic therapy. In those patients with the primary pulmonary hypertension, maybe some vasodilators, but these tend to be more palliative than anything else. And therefore, it's the main message is that when we get to a very severe tricuspid regurgitation, we have very few medical therapeutic options.
Thank you. Ovidio?
So, Mariana, I fully agree with you. We don't have clear algorithms for tricuspid regurgitation. First of all, I remember what Julia said. It's tricuspid regurgitation, it's load dependent. It's even more load dependent than mitral regurgitation, and any change in fluid rapidly influence severity of tricuspid regurgitation. I'm not talking here about advanced heart failure. I'm talking about heart failure per se. The second issue, it's about anatomy. We don't have a clear definition of tricuspid annular space, as in mitral regurgitation, when it's a very well recognized anatomical component of mitral annulus, totally distinct to tricuspid annulus, which is a place where tricuspid leaflets are inserting. And the last issue, what Andrew said, and also Giuseppe, about optimization of medical therapy. Commandments in tricuspid regurgitation is use and uptitrate diuretics and avoid fluid overload, nothing more, because on long term, any pharmacotherapy to improve right ventricular atrial coupling, there are not evidence-based except for patients with pulmonary disease. So we have very few resources in terms also of surgery or structural interventions.
Marco, do you want to conclude?
Yes, nothing to add to what said before, to which I fully agree. We have, in patients with FREF, we have optimization of medical treatment, and it is clearly shown what it can do. If the patient has concomitant severe mitral regurgitation, we have the option of percutaneous treatment of mitral regurgitation. Let's remember of atrial fibrillation and maybe the chicken and the egg, but in some cases, treatment of atrial fibrillation, even PV ablation, may have an impact on tricuspid regurgitation. In the end, we have all these patients with severe tricuspid regurgitation in whom the only thing we can do is to optimize diuretic treatment and to optimize volume status. And this is further complicated by the kidney dysfunction, which is maybe caused by the venous congestion caused by the tricuspid regurgitation. And this kidney dysfunction is clearly associated with resistance to diuretic treatment. So it's there is a clear indication to help the patient at an earlier stage. There is also a question regarding the cutoff of pulmonary artery pressure but question. We can consider this.
As we know, pulmonary pressure is underestimated by echocardiography. So these patients have to perform right heart catheterization in order to assess pulmonary pressure levels. Julia.
So this is a limitation that is known to us as echocardiographers, that when you have torrential tricuspid regurgitation and there is a huge coaptation gap, you cannot measure right ventricular systolic pressure because the Bernoulli equation is not valid. So that means then we have to liaise on right heart cath values. And we saw also that Philip performed right heart cath. I would be very interested to see, how he describes. He describes nicely the right heart values. But remember this as the main limitation of echo, that then we will divert to right heart cath to learn the right ventricular systolic pressure. Just a short comment that when we have right ventricular systolic pressure, remember that it's always indexed to age and also body surface area. So when a patient is obese, we are expecting slightly higher right ventricular systolic pressure than the normal cutoff values.
I think, yes, Philip would be welcome at this stage. I mean, from the chat, they asked whether there are numbers that contraindicate a percutaneous treatment of tricuspid regurgitation, numbers from the hemodynamic study.
Yeah, I mean, that's a very important question, but a question with no easy answer to. When it comes to clinical trials, most clinical trials excluded patients with RV pressures beyond 60 millimeters of mercury, but I guess that was slightly arbitrary at the beginning. From our data, we can say that there is no clear cutoff in terms of RV pressures beyond we see no clinical benefit, or beyond maybe the intervention might be even detrimental. What is relevant is the differentiation between post-capillary or combined post and pre and isolated pre-capillary pulmonary hypertension. That is of relevance because those with a significant pre-capillary component, they have an inferior outcome as compared to those with post-capillary pulmonary hypertension only. However, having said that, since we don't have randomized data, we don't know whether they would have done even worse without any treatment. So that's important when we talk about all these predictors for outcome, that obviously we see worse outcome in more extreme advanced disease, but we don't know what would have happened without treatment, obviously. So overall, no clear cut-off point, but the differentiation between post and precapillary pulmonary hypertension, and this is something Julia alluded to already, whenever you see a marked underestimation of RV pressures on echo, but high invasive pressures, so we refer to that as a discordant diagnosis of pulmonary hypertension that again indicates worse prognosis. And this is why invasive assessment is so helpful in these patients.
So Philip, 60 millimeters of mercury as systolic pulmonary artery pressure, no precapillary component. Would you like to say something regarding the cardiac output?
So maybe again, this 60 millimeters of mercury cutoff, that's the cutoff for clinical trials. This is not what we use in clinical routine. We would not exclude treatment of transcatheter treatment of TR in a patient with a 70 millimeters of mercury when it's isolated post-capillary. So I don't think there is a clear cutoff point. It is only in clinical trials so far. And then cardiac output is really interesting because when we looked at that, we thought that the lower the cardiac output, the worse the prognosis is. But interestingly, and it is true, those with a lower cardiac output to start with, they had worse prognosis as compared to those with normal cardiac output. But there is a specific cohort of patients with severe TR. They have rather supranormal or high cardiac output. So they have something like high cardiac output failure. And those are patients with more advanced liver disease, with therapy-resistant ascites. So they have something which is also known from primary liver disease, which is high cardiac output failure. So I guess it's a very complex issue, but I guess one should not be misled by cardiac output measures and think that those with very high cardiac output are better off than those with low.
Excellent. I think that we can look at the conclusions of our cases. So, Philip, if you want to start.
Yes, just have to advance the slide. Yes. So remember, we had a patient with HFpEF, with clear diastolic dysfunction. And we thought about whether we should treat the patient. And we eventually, obviously, did by transcatheter means. We were quite successful in reducing TR. But the question was, if you reduce TR and if you increase forward flow to the pulmonary artery through the lung, and thereby also increase left-sided venous return, could that actually make HFpEF worse? Could it actually make diastolic dysfunction worse? And we saw the opposite. If you treat TR, then your LV filling gets better because, and this is, I guess, nicely illustrated by this MR, again, a short axis view on the right side showing that the RV is now much smaller. It leaves more space for the LV to fill within a restricted pericardial space. And therefore, we can also demonstrate we see more LV filling at lower LV filling pressures. And this, again, illustrates the importance of ventricular interaction in HFpEF and TR, and also the positive effects when you improve the ventricular interaction.
Impressive case. Congratulations. And Julia, what about your patient?
So for us, we had a multidisciplinary meeting. And of course, a tricuspid intervention would actually help in the symptomatic relief of the patient. However, if you think that the patient is 61 years old and he has a background of DCM, and also he has severe TR on optimal medical management and CRTD, we felt that the best pathway would be to have a heart transplant because he's the best candidate. And that's why at the moment he's listed for a heart transplant, and he's stable actually in your heart association between 2 and 3, and he's waiting for his turn to have the procedure.
Good.
Perfect. Even because probably the anatomy of your patient was not
It was not
optimal.
favorable. So
Exactly.
yes, first is the anatomy is not favorable, so because he has the septal impingement. So it would be extremely difficult or even impossible to place a triclip. But even for a tricuspid valve replacement, we felt actually that the patient has already is maybe a bridge again to transplant, because there is no destination as that the patient would be having this effect that Philip nicely showed us, because the patient has DCM, so he's already a heart failure patient with established cardiomyopathy. So he needs a treatment which would be actually the heart transplant as number one.
As we have 1 minute, may I ask to Philip whether this role of ventricular interdependence is in how many patients you see this with FPEF, with atrial TR, which proportion?
Yeah, I mean, this is obviously quite an extreme case with a very good outcome and almost complete reversal of that very specific pathophysiology. We do see septal bowing in those patients in whom post-capillary pulmonary hypertension is quite marked, because obviously this is a consequence of RV pressure overload and prolonged shortening of the RV while the LV is already filling, the RV is still contracting, and therefore we see that very marked septal bowing. Overall, we see that I'd say maybe in 15% of all HFpEF patients with TR, but maybe not to this extreme extent.
Perfect. So if there are no questions from the chat,
No.
I would like to make a question to all the team about how can we improve the cooperation between heart failure specialists, interventionalists, and imagers in order to improve the management of patients with the tricuspid regurgitation and the heart failure. Ovidio, do you want to start?
Yes, thank you so much, Mariana. First of all, I think the first message would be understanding the problem, because heart failure generating tricuspid regurgitation and tricuspid regurgitation negatively impact progression of heart failure. The second message would be we should not contemplate patients with severe tricuspid regurgitation and advanced heart failure. What Giuseppe and Andrew said, that we have reserve of optimization in less advanced stages, it's completely true. The third message, in my opinion, would be just taking the point from Philip, is to distinguish exactly which is a primary factor for tricuspid regurgitation. It's tricuspid regurgitation per se in case of primary tricuspid regurgitation, ICD lead, is right ventricular dysfunction, or it's pulmonary hypertension associated to left side diseases. And finally, I should say that for sure we need a multidisciplinary approach, because beyond of echo in terms of severity, size, function, leaflet gap, cardiac output, pulmonary pressure, we need integration with clinical science, as Andrew pointed out very nicely at the beginning. We need to have all this data also in conjunction with biology, with end organ dysfunction markers, with specific tests, as Giuseppe said, about hepatic elastography.
Thank you. Giuseppe?
I think it very much depends on which perspective we come from. And if that is for patients with heart failure, I think it should be heart failure team, and where all the different specialists and all the different actors play together, going from imaging to intervention. So, and that is probably the best way to improve care of patients with heart failure, but in general, patients with heart disease. So the heart failure team where available, or the heart team should be should be more and more pursued in centers where, whilst we often see that that in the different departments there are isolated management of patients that go just to one department, and therefore they take a preferential pathway because of a specific interest, rather than pursuing the interest of a patient that is better served with a more integrated care.
Thank you, Andrew.
I think critical, I very much support what Ovidio and Giuseppe have said, but the critical thing is communication. And we talk about the heart team, but the heart team has to have a way it can get together. And I think we underestimate the value of old-fashioned things like case conferences where interesting cases are brought together and all the participants from imaging, from intervention, from medical management, heart failure, and for many cases also surgery are on board so they can all look at the cases. What that does is it accumulates all the necessary information and accumulates all the necessary perspective, skills, and clinical acumen to be brought to the case. And having listened to Giulia's great presentations, you realize how much more is available from modern imaging. But if you simply do a tick box and say, oh, we've done an echo and that's sufficient, that's not getting all the information we need. So if we talk to the imagers on a regular basis, then they can direct us what's the most appropriate imaging, and they can do special studies. If we're contemplating a tricuspid intervention, then the nature of an echo or a MRI scan is completely different because they'll want to look at the detail as Giulia's presented. So I think the heart team and the case conference are fundamental in getting the optimal decision-making for these complex patients.
Thank you, Andrew.
Marco?
I think you pointed out the issue of communication. The communication is really the basis of everything. And the other starting point is the clinical signs and symptoms of the patient, which is the other start. So patient and communication between different specialists. I don't know if we want, we have received from the chat a very specific question regarding...
There is a question maybe about the PAPI score in the decision making. So if you take into account this score in the evaluation of patients for a transcatheter treatment. Philip, do you want to reply?
Cutoff values for right ventricular function also were asked.
Sorry, which score was it?
The PAPI, we call it in Italy, but I don't know if it is the same.
Right. Well, I personally have not used this score, and I might not be the right one to comment on this. Maybe I can say something about right ventricular function, and then Giulia can jump in on the other one maybe, because that's obviously also very relevant. RV function. When we started, there was always the concern that when we treat TR, we might increase RV afterload, and this could actually cause the RV to fail. And as a general note, we don't see that. We don't see RV failure after treating TR, at least not when it comes to repair. It might be a different story with replacement, where we are just at the beginning, but with repair, we don't see RV failure. So I'm not sure whether there is a true cutoff value in terms of RV function, meaning that at a certain degree of dysfunction, TR should not be treated anymore. We don't have the data yet. When it comes to prognosis, again, obviously, worse RV function, worse prognosis, also after treatment. But this is the late prognosis, again, no acute failure.
I think that, the problem of an increase in right ventricular afterload may occur just if you have precapillary pulmonary hypertension. In this case, yes, there is the problem of the afterload. But otherwise, the pulmonary vasculature is generally more able, for sure, than the systemic vessels to adapt to a larger cardiac output. And so there is much less the problem of right ventricular afterload after correction of TR.
A quick question, like a point that we have noticed now that patients that they had an tricuspid intervention and the reduction is, for example, from severe to moderate, they still have symptomatic relief. And because as long as you try to reverse, to stop the hepatic vein reversal, I think the patient will symptomatically get better, isn't that?
Yeah.
So
This is extremely important.
Exactly.
We have to look not only at the prognosis, but also the quality of life and the improvement of symptoms. So we have to move to the recap.
Yes, thank you, Marianna. And but at least, with everything that is new, like intervention on TR, they make us think about things that we were not thinking before, like ventricular interdependence, like clinical evaluation, like assessment of end organ dysfunction is more actual now than before. So to recap, we have discussed possible causes of secondary tricuspid regurgitation and mainly atrial at an early stage of the progression of heart failure, generally with FPF, generally with atrial fibrillation, and then the ventricular tricuspid regurgitation where right ventricular dysfunction becomes the main cause, and this is generally in a more advanced progression of the patient. We have discussed the importance of the early identification of tricuspid regurgitation in the patients with heart failure, hopefully before visceral congestion and end organ dysfunction, liver, kidneys, gut becomes irreversible. And then we have discussed the role of hemodynamic monitoring and medical therapies. And we know that in the end, after we have treated FRF with guidance-directed medical treatment, it remains the main aspect of treating congestion and optimizing the volume status, and mainly with the diuretic treatment. Then, to the end, we have discussed the possible role of tricuspid valve interventions. And here we have the gap because we have on one end surgery, which is burdened by a high intraoperative risk as assessed generally by the 3 score, but many times the intraoperative and perioperative mortality is too high to propose it. On the other end of the spectrum, we had medical treatment just with diuretics, and so this gap may be hopefully filled by percutaneous interventions, and you see that there is a wide range of interventions that are coming to our attention nowadays. And with this, I thank you on my side, and
thank you for this recap, and I would thank all the team for their excellent contributions. I would like to thank also Francesco Maisano and Fabien Prats for this opportunity, and all the participants for having joined us. Thank you.